Robinson from the UK, and this case that we're looking at today is a 31-year-old female professional soccer player. So if we move on to the history, we were told that the knee pain occurred acutely with no direct trauma after landing from a jump. There was immediate knee pain and swelling with a feeling of instability with positive tests for an ACL tear. And as commonly happens with professional players, there's no need for an x-ray. People are reasonably confident there's no significant fracture, and an x-ray on its own isn't going to add a lot. And really we want to know, we already expect that there's going to be an ACL tear, and we are really looking for those associated injuries, as you'll see. So in this, we had to highlight the injuries, and one of the injuries we were going to see obviously was complete disruption of the ACL. And then on the other injury we were looking at was this postremedial capsule or ramp lesion, which we'll discuss as we go through the cases. So if we move on to the MRI proper, I usually start with the PD sagittal, and as you go through, you can see already there's a massive effusion. This is a hemarthrosis, but there's no lipohemarthrosis in this case, which was one of the questions that we were looking at. We can see that the ACL is torn. We can see that the PCL is intact, which was another question. And we can also see the pivot shift distribution of bone marrow bruising. So we can see in the posterolateral tibia, the lateral femoral condyle sulcus, and across into the postremedial tibia as well. And so if you see this bone bruising in the context with a large effusion, you immediately suspect there's been an ACL mechanism of injury, which we've confirmed here. So now if we look laterally, we can see that the posterior horn of the lateral meniscus, as it comes in to merge with the meniscofemoral ligament, is abnormal and torn, and some people call this a Risberg rip, or a rip between the ligament and the meniscus. And then as we go further lateral, the meniscus itself begins to take a more normal shape, although it's still got the tear extending through it, and we can see the superior and inferior popliteal meniscopopliteal sheath fascicles. The anterior horn is often edematous and injured when there's an ACL injury because of the close anatomical relationship, but rarely is it clinically significant. If we come back across now into the medial compartment again, we can see that we have the posterior horn of the medial meniscus, and the medial meniscus remains intact throughout. We'd of course will always check this on the other planes, which we'll come to in a moment. But we can see now immediately there's an abnormal meniscocapsular junction with a defect through this area. And again, this is called a ramp lesion by some, because when the arthroscopist is looking in, they see a kind of defect in the ramp of this connective tissue interface. We can see there's a subcortical fracture, which again is another of the questions. Again, it's not displaced. Clinically, it's not relevant, as the patient will be undergoing rehab anyway. There's bone bruising through this area and also through the other soft tissues. So this postremedial injury is really a postremedial capsular injury. The lateral meniscus, we've talked about the bone bruising over here, there's no fracture. So what do we see on the other sequences? Well, if we look at the coronal T1, we just see the bone bruising, typically. In this case, you see that there's loss of some of the fat signal deep to the iliotibial band, which we'll come back to. And here's this subcortical fracture in the postremedial corner. So as we move through on the coronal PD weighted, we can again see this edematous area involving the meniscocapsular junction. And as we become more posterior, we see there's edema overlying the MCL. So this is at least a grade 1 MCL at this point, but the main ligament remains intact. But as we go more posterior, you can now see that there's intrinsic edema, making it a grade 2. And as we carry on posteriorly, we see that this area here is the injured posteromedial capsule. As we scroll back again, we can see the disrupted ACL and the intact PCL. And as we go to the posterolateral corner, we can see the bone bruising, but actually the soft tissues in this region are reasonably good. The biceps femoris, the femorofibular ligament is intact, but there's overlying edema. And some of that fat signal that we saw that was lost on the coronal T1, we can see as ill-defined shadowing here. And this is a controversial area now. We're into the region of the Kaplan's fibers deep to the iliotibial band. We can see at the level of the normal popliteus tendon, and it's going anteriorly, there's marked edema of these linear structures, and this is considered to be the anterior longitudinal ligament complex, which some people now believe has to be repaired to give good stability post-ACL reconstruction. So if you were describing this, what would you say? Well, you would say that these tissues are edematous, including the tissues deep to the normal iliotibial band. We can see where this meniscotibial ligament is stretched and edematous but remains intact. And of course, if this was avulsed, this is where you would get the secant fracture. We can see that the tissues superior to this are also edematous. So this is the kind of junction area that you look at, and you use your popliteus tendon as the posterior margin of it. So really you're looking posterior, it looks okay. Popliteus anterior is where you get the anterior longitudinal ligament injury. So if we look on the axial sequence to finish off, we can, I'll just zoom this in. We can see that there's a fissure in the in this area of the cartilage, which is obviously chronic, not an acute injury at all. We can see the hemarthrosis again. As we come down, you always get a nice view of the ACL, so it should be a nice low signal structure at this point. You can see it's edematous with some persistent fibers here, but quickly, as we go more inferiorly, it becomes completely disrupted, and we see the normal PCL. Again, if we focus on the medial side, we can see that intact medial collateral ligament with edema deep to it and superficial. And as we come down, we can see that posteromedial corner injury, and the posterior oblique ligament is disrupted. Likewise, on the lateral side, we can follow the popliteus, the femorofibular ligament, the biceps femoris tendon as they start to merge to form the conjoint tendon. And there's relatively little soft tissue edema in this region. There's no ligament disruption, and we have the adjacent bone bruising. We have the normal iliotibial band, and then in between we have this edematous tissue, which as we go up, you can see that area that we were looking at on the coronals as being the anterior longitudinal ligament complex. So if we now go through a summary, anterior cruciate ligament tears are usually non-contact, as in this case. So it's usually in soccer players, particularly where they change direction, they land from jumping. It's not usually a contact with another player. And it's thought that as the land or the change in direction, as the foot becomes fixed, it's the rotational component of the rest of the body which causes the ACL and that pivot shift injury. As we've discussed, the bone bruising distribution suggests it, and it confirms that there's always a translational and rotational component to this injury, and that's why there's so many variable associated injuries with an ACL tear. As we discussed, X-rays are usually non-specific, and MRI is quickly used to assess. So here we just confirm again, the yellow arrow showing the ACL tear, the green arrow, the lateral meniscal tear at the junction of the menisco-femoral ligament. We've got the bone bruising in that area. Oops, sorry. Then we have, hold on, let me just go back. So the associated injuries that can occur are these rotational, tensile, and compressive vectors. So we get post-remedial corner injury when it's localized to the meniscus as a tear. Some people call it a ramp lesion. You can have an associated osteochondral injury, as you've seen in this case, where there's a subcortical fracture, but it's rarely clinically significant, whereas the meniscal tear or the meniscocapsular injury can be. The medial collateral ligament can be involved, as in this case, along with the posterior oblique ligament. The lateral meniscus tear quite often involves the junction with the meniscofemoral ligament, as in this case, and this case also had an anterior longitudinal ligament complex injury. These areas, the postremedial corner and the anterior longitudinal ligament, have really only been relatively well described in the last 5 to 10 years from a clinical and imaging point of view, and are controversial in terms of what surgeons think need to be done to address these injuries. So it could be quite variable, with people who don't believe they need to be repaired to those who do a full reconstruction. So here we have the postremedial corner injury. Again, we can see the injury at the periphery of the meniscus, but the meniscus itself remains intact. When the meniscus is torn, it is usually a longitudinal tear in this force vector, where we can see the bone bruising, we can see the capsular injury involving the posterior oblique ligament, we can see the subcortical fracture, again, more of the subcortical fracture, and as we saw in the axial images, you get a nice view of the disruption of the postremedial corner extending from a largely intact MCL. Again, as we saw on the coronals when we were looking at them in the stack, that we have this MCL injury, we have this postremedial corner injury, and then if we take the femoral fibular ligament and then the popliteus as our posterior margin of the anterior longitudinal complex, so beyond these two structures is where the longitudinal complex is described, we can already start to see edema deep to a normal or otherwise intact iliotibial band. And on the axial sequence, again, we've got popliteus, we've got the femoral fibular ligament, and anterior to it, we have soft tissue injury. So that's the case completed. So it's an ACL tear, but that often isn't the challenge for us as radiologists. The challenge is to define all the other associated injuries, and the relevance of these will depend on what your surgeon believes is required. Here are some references to help you further evaluate these areas, looking at the postremedial corner, the ramp lesions, the anterior anterolateral structures, including the anterior longitudinal ligament complex. And this bottom article is an excellent general review article of MRI of cruciate ligament injury. Thank you very much.